Hello, guys. So today's topic is abdominal pain. Abdominal pain is one of the very common presentations we encounter on daily basis in our OPD, and it is a very common presentation which can lead to different diagnoses. So, how are we going to approach a patient with abdominal pain, and how are we going to diagnose it? What can be the differential diagnosis? What are the things to we have to look for? First of all, if a patient comes to you with abdominal pain, we have there it can be acute abdominal pain or chronic abdominal pain. If he has the acute abdominal pain, the differential diagnosis or probable diagnosis can be acute gastroenteritis. If a patient is coming to you with the complaint of abdominal pain and he has diarrhea and vomiting, acute gastroenteritis can come into our mind. Then we have appendix. A female patient can experience dysmenorrhea, irritable bowel syndrome, biliary or renal colic. These can be the probable diagnosis. And if the patient is complaining of the pain to be chronic, it can be due to IBS, diverticulitis. Dysmenorrhea can also be of chronic cause. And then we have gastritis. What are the serious disorders which should not be missed? Actually, we are following the John Murtagh model of diagnosing any disease, of how to approach a presentation. One second. We have serious disorders which should not be missed, which are not to be missed in any case. And if they are missed, there can be lethal outcomes or there can be mortality. For example, if a patient is coming to you with abdominal pain, there can be cardiovascular causes. For example, MI, if a patient has epigastric pain, or sometimes umbilical pain, which is radiating towards upper side, it can be due to MI. Then we have abdominal aortic aneurysm, ruptured abdominal aortic aneurysm. Then we have mesenteric artery occlusion. These can be cardiovascular causes. Then we have neoplasia. And in neoplasia, we can have large or small bowel cancer, infections, peritonitis, salpingitis, cholangitis, and abscess. And there can be pancreatitis. And ectopic pregnancy is a very important diagnosis we should keep in mind. In If a patient is female, she is married, and the patient has missed her periods. Then we have a small bowel obstruction, sigmoid volvulus ulcers. These are some of the disorders we have to look for if a patient is coming to you with acute abdominal pain. Then, if the patient is coming to you with chronic abdominal pain, cardiovascular causes can be the same. Neoplasia can come as bowel cancer, pancreatic cancer, or ovarian cancer. Infections, chronic infections like pelvic inflammatory disease and hepatitis. These can be the causes of chronic abdominal pain. Then we have pitfalls. What are the pitfalls? These are the common disorders that often get missed. Like the patient can experience muscle pain or muscle tear due to heavy workout or athletic work. Then, if the patient is elderly and he's experiencing abdominal pain, the fecal infection is one of the diagnoses which can come into our minds. Pitfalls in the chronic abdominal pain can be due to adhesions. If the patient has a history of multiple surgeries, can be food allergies like lactose, lactase deficiency, celiac disease, fecal infection. Chronic pancreatitis can one of the causes of chronic abdominal pain. Endometriosis is often a diagnosis which gets missed if in a patient who are in a female patients who are experiencing lower abdominal pain, who are experiencing dysmenorrhea. This is a very common disorder which gets missed easily. Then we have lead poisoning. Then we have the list of seven masquerades. Seven masquerades are depression, drugs, diabetes, endocrinology, endocrine, spinal, UTI, and anemia. These can also directly or indirectly present with abdominal pain, and we have to look for if all the other diagnoses are not coming into our mind. Then we can go towards seven masquerades list. If the patient is taking some certain drugs which can cause acute abdominal pain. If a patient has diabetes, for example, the patient has diabetes and sugars are markedly elevated, and the patient is experiencing abdominal pain, he can there can be a diagnosis of decay in mind. Endocrine, likewise endocrine and spinal, if the patient is lumbar pain and it is radiating towards abdomen, it can also uti, anemia. Then we have red flags. Red flags are very, very, very important to look for every abdominal pain. If the patient has history of collapse, for example, a patient goes to toilet and he push to defecate, he and the patient collapses. It can be due to intra-abdominal bleeding, due to rupture of an abdominal aortic aneurysm, due to Valsalva maneuver. This can be a history point we have to keep in mind. Then we have, if a patient has lightheadedness, it can also due to bleeding. Ischemic heart disease, if a patient has a history of ischemic heart disease, mesenteric artery occlusion can come to our mind. Then we have vomiting, pain, and distension, menstrual abnormalities, and malignancy, history of malignancy, and lack of flatus. Lack of flatus can point towards the small bowel or large bowel obstruction. Then we have signs to look for. What are the signs which can be red flag? Pillar and sweating, decreased blood pressure, atrial fibrillation and tachycardia, fever, rebound tenderness and guarding, and decreased urine output. These are the red flags which we have to keep in mind. Okay, so following the series of acute abdominal pain, in second part we will further proceed towards some detailed things like pitfalls. We have appendicitis if the patient is elderly, and if the patient is child and pregnant and on steroid use, appendicitis gets often missed easily. Lactase deficiency, the history point which can point towards this disorder is that after the ingestion of milk, the patient is experiencing watery stools. It can be due to lactase deficiency. And if a patient is the user of contraception or combined oral contraceptive pills, ectopic pregnancy can easily be misdiagnosed. And if the patient has menstrual abnormalities, ectopic pregnancy gets easily misdiagnosed. So we have to keep this diagnosis in mind. Then we have spinal dysfunction, which can cause rapid abdominal pain. This can also be easily missed. Then we have some of the drugs which can cause abdominal pain, like alcohol, antibiotic, like erythromycin, aspirin, steroids, cytotoxic drugs, iron supplements. Often, not every patient can tolerate iron supplements. They Many people complain of diarrhea and abdominal symptoms. Then we have NSAIDs. NSAIDs can cause ulcers and abdominal pain. Sodium valproate, phenytoin. These are some of the drugs which can cause abdominal pain. Oh, okay, so we have every disease have some pointers and some indicators which can lead towards a certain diagnosis. For example, finger pointing. If the patient is finger pointing towards a certain area, in that he has pain on that area, we can say that it is due to focal peritoneal irritation. And if the patient is um, making a sign of a spread palm, it can be visceral pain and visceral origin. The whole organ is involved. If the patient has a history of atrial fibrillation and abdominal pain, it can point towards mesenteric artery occlusion. And if the patient is having tachycardia, and if the patient is having tachycardia, it can point towards tachycardia, tachypnea. It can point towards sepsis and volume depletion, tachypnea, pneumonia, and acidosis. These are some of the pointers. Then we have Pelarian shock. It points towards acute blood loss. And if the patient is having silent abdomen on auscultation, it can be due to diffuse sepsis, ileus, or mechanical obstruction, advanced mechanical obstruction. Then we have, if a patient is having distension on examination, there are the 6F which can come into our mind. That is fat, number one, fat. They can be fluid, like SITs. Then we have flatus. Then we have feces, like fecal infection. It can be due to pregnancy, and the distension is due to fetus, and the frightening growth, any mass, any cancer. Hypertympanic. If the abdomen is hypertympanic, it signs towards mechanical obstructions. What are the investigations we have to do for abdominal pain? CBC, ESR, CRP, baselines, beta HCG. If a female patient is experiencing abdominal pain, we have to rule out pregnancy first. Then we have LFTs, amylase, lipase, fecal elastase. If the patient is, if we are suspecting chronic pancreatitis, in urine, on urine examination we can see blood. If there is blood on urine dr, it can point towards ureteric colic or urinary infection. WBCs are raised on in urine sample, then it is due to UTI or appendicitis. If due to bladder irritation, bile pigments are there, that can be due to gallbladder disease. If there are ketones, increased ketones, it can be due to DKA, diabetic ketoacidosis. If there is air, it can be due to pneumaturia. Pneumaturia can be due to diverticulitis, pelvic abscess, pelvic cancer. And if the patient is having fecal blood, it can with along with abdominal pain, it can be due to mesenteric artery occlusion, intussusception, colorectal cancer, Crohn's disease. Then we have ultrasound and CT scan. X-ray, erect and supine X-ray is a very good imaging. We can have crescent sign under crescent sign on erect and supine X-ray if the patient has a ruptured bowel, or it is called as air under diaphragm. Kidney and ureteric stones can be seen, air in biliary tree, blurred dried sauce, shadow. It can be due to appendicitis. If there is a sign of coffee bean, it can be due to volvulus. If there is sentinel loop of gas in left upper quadrant, it can be due to acute pancreatitis. Okay, coming towards what are the sites of pain, and what sites of the pain are referring to. Sites of pain, unusual conditions, like for example, if the patient is having epigastric pain, it can be due to lower lobe pneumonia or myocardial infarction. These can be the unusual conditions, apart from abdominal conditions. If the patient is having a periumbilical pain, it can be due to ruptured abdominal aortic aneurysm or mesenteric ischemia. If the patient is having right iliac fossa pain, it can be due to Meckel's diverticulum and mesenteric adenitis, apart from appendicitis. If the patient is having right iliac fossa, the very number one diagnosis comes to our mind is of appendicitis. But these two are also the conditions we should keep in mind. Then they have left iliac fossa. It can be due to diverticulitis. If the patient is having lower abdominal pain, it can be due to large bowel obstruction and PID and other menstrual related pains. If the patient is having suprapubic pain, it can be due to ectopic pregnancy. If the patient is having groin pain, it can be due to hernial orifices. We have to check hernial orifices in a small bowel obstruction. And also the kidney pain and ureteric colic can also referred from loin to groin. Acha, what can be the causes of acute pain in children? What are the common causes of acute pain in children? It can be infantile colic, which it is a very common presentation in infants, and it is a very common cause of crying and irritation in children, in infants. Um, Gastroenteritis and mesenteric and adenitis. These are the common disorders. What are the serious disorders which can cause acute pain in children? Are intussusception and acute appendicitis, bowel obstruction, or strangulated hernia. What are the pitfalls? Child abuse is often get missed. Constipation can be there. Testicular torsion, lactose intolerance, and infection. These are the disorders which get missed routinely. And Simon masquerades can be due to in children. We have to keep in mind type 1 diabetes, and can be due to drugs and UTI. What can be the cause of recurrent abdominal pain in children? It can be organic or psychological. How can we differentiate between these two? Organic, if the child has having psychological abdominal pain and it is recurrent, it can be the signs we have to look for is the that the pain is usually less than 60 minutes and the child is anxious and he is obsessive, right? And if the pain is organic in nature, it can be radiating. Sleep can be disturbed, nausea and vomiting can also be associated, and weight loss and failure to thrive would be there if there is an organic cause of abdominal pain. What can be the abdominal causes of abdominal pain in older people? It can be ischemia or embolus. Cancer is a very important diagnosis we have to keep in mind. Then there is fecal impaction, diverticular disease, and non-specific signs like confusion, anorexia, and tachypnea. These are some of the signs we have to look for in older people, because older people and elderly people are not good at telling their symptoms properly. So these are the symptoms and signs we can look there. Okay, now coming towards disorders one by one. First of all, in we have to see the cause of abdominal pain in children. There is intussusception. Intussusception is a very important diagnosis, and it's the foremost diagnosis we have to look for if the patient is 3 months to 2 years old and the patient is experiencing very severe pain. Sudden acute abdominal pain, and there is vomiting, and there is a red currant jelly in the stool. 2 to 3, the pain is of 2 to 3 minutes with 15 minutes interval usually, and there would be obstruction. And on imaging, we have sausage shaped mass in upper quadrant, and we can palpate it. Diagnostic triad can be the patient is pale, severe colicky pain, and there is vomiting, and the patient is 3 to 2 years old, 3 months to 2 years old. It is the very important diagnosis we have to look first. Then we have mesenteric adenitis. Mesenteric adenitis, the pain is in right iliac fossa, so it can easily be taken as acute appendicitis. What And the signs and symptoms are almost similar to appendicitis. There is increasing fever pattern. There would be flushed face, and in children, how are we going to differentiate between the two? The pain of acute appendicitis is less severe pain. On the other hand, the pain of mesenteric adenitis is less severe. Appendicitis condition of appendicitis is usually seen in older children, while mesenteric adenitis is seen in younger children. In the appendicitis, there is usually no history of infection. In mesenteric adenitis, there can be a history of infection of upper respiratory tract. On palpation and on examination, there would be guarding and rigidity on palpation, while in mesenteric adenitis, there is no such thing. There would be pain on palpation, tenderness would be positive, but there wouldn't be any guarding and rigidity. On CBC, there would be leukocytosis. On the other hand, in mesenteric adenitis, there would be lymphocytosis. Then we have acute diverticulitis. It is in mostly in patients more than 40 years old, and it is a long-standing condition. The left abdominal pain plus constipation, irregular constipation. If the patient is complaining of left abdominal pain, pain in left iliac fossa, and there is constipation irregularly, then we have acute diverticulitis in mind. Diagnostic triad can be acute pain, left radiation, fever plus constipation. There can be mass palpated in left iliac fossa. Pus or blood in stools can also be present. On CT, we can see fistula, abscess, or perforation. X-ray, on erect X-ray, there we can see crescent sign or air under diaphragm if the perforation is suspected. What can be the complication in elderly patient? There can be profuse bleeding, perforation or fistula or abscess. Then we have abdominal aortic aneurysm. On examination, there would be pulsatile mass, and family history can be positive of abdominal aortic aneurysm. Some things, if the abdominal aorta diameter is 0 to 30, it is normal. 10 to 30 is normal. If more than 30, it is nervous aneurysm. If more than 40, we have to refer, and if it is more than 50, we have to operate. The investigation of choice is helical or spiral CT. MRI gives the best definition of abdominal aortic aneurysm. Ultrasound screening in first degree relatives over 50. If the patient is over 50 years of age, if the patient has a history of abdominal aortic aneurysm in family and the relative is first degree and over 50 years of age, and then the ultrasound screening is can be done in other in him ultrasound screening can be done. Then we have rupture. Rupture is surgical emergency, and the patient is having severe acute abdominal pain, and he can give a history point of patient collapse at toilet as need to defecate, but Valsalva, due to Valsalva maneuver, there is intra-abdominal bleed. Diagnostic triad can be intense abdominal pain, pale, and back pain. Then we have mesenteric adenitis, mesenteric artery occlusion. Acute intestinal mesenteric artery occlusion or acute intestinal ischemia. If there is a history of thrombus or embolus, the patient is complaining of central intensing pain and fear of he has a fear of eating due to intensity of pain, and the patient is confused. Diagnosis can be anxiety, prostration, plus intense pain, plus profuse vomiting, or plus or minus bloody diarrhea. What can be the signs? The signs could be rebound tenderness over infarcted bowel, thumb printing. On a plain X-ray, we have a sign of thumb printing. Then we have CT scan. CT scan gives the best definition, and if the embolus is suspected, we have to do angiography. Okay, on proceeding further, we have acute retention of urine. How can we acute retention of urine is also a very common complaint in, especially is also a very common cause of abdominal pain in elderly patient. The patient can complain of severe pain, may not be obvious. Senile and old and bedridden patients can experience this type of complaint. Um, can be the causes due to prostate hypertrophy, bladder neck obstruction, bifecal impaction, pelvic mass, anticholinergics, and it can also precipitated by cold. Neurological causes can be multiple sclerosis, spinal injury, and diabetes mellitus. These can be the causes of acute retention of urine. Fecal infection. Fecal infection can resemble malignant obstruction. A patient can patient can also complain of spurious diarrhea or fecal incontinence and fecal infection. In elderly patient and especially bedridden patient, they cannot tell you about urge to pass stool, so they often get fecal infection due to immobility. The stool, they can experience constipation, and there is fecal infection, and the abdominal pain can be due to this cause. Then we have appendicitis. Appendicitis is classical left iliac, right iliac fossa with ventrals the pain of appendicitis can be migratory. There can be there would be anorexia and nausea, um, temperature, raised temperature, and These are the signs of appendicitis, and if the site of appendix is pelvic, the patient is can complain of urinary frequency, diarrhea, tenesmus, and the per rectal examination would be very tender. If the appendix is retrocecal, there would be loin pain. And in pregnancy, usually many patients complain of appendicitis during second trimester of pregnancy. Then we have another cause of abdominal pain, which is peptic ulcer. Diagnostic triad can be sudden severe pain, anxious, sweaty, deceptive improvement. Means the patient is relieves patient gets relieved temporarily when the ulcers gets perforates. Patient lies quietly still, and there is bored rigidity. Duodenal ulcer, the pain of ulcer gets after 2 to 3 hours of meal. But then we have the pain of kidney stone. The pain of kidney stone, it is classical in loin to groin type of pain. There is kidney, the ureteric colic and the renal colic is a very severe pain. Patient can experience nausea, vomiting, and he is writhing, and he do not get comfort in any position, and that is a very severe kind of pain. The patient is complaining of pain radiating from loin to groin. Patient can experience blood in urine, and there can be burning micturition due to infection. When we have to refer the patient of kidney stone, if the stone is more than 7 millimeters and the obstruction is high or bilateral obstruction, there is gross hydronephrosis on ultrasound, there is infection, diabetes, and the kidney is solitary. Means the patient has only one kidney. These are the points when these are the things when we have to refer the patient. What can be the biliary causes of abdominal pain? Biliary pain may radiate it to right shoulder or scapula. Diagnostic triad can be severe pain, vomiting, and the pain can be radiating. And there can be tenderness. And then we have acute pancreatitis pain. The patient can have hyperglycemia and hypocalcemia disorder, complaints of hyperglycemia and hypocalcemia on lab investigations. And if the patient is having acute pancreatitis, we have to do CT after 48 hours to look for any complication. Autoimmune pancreatitis, the patient can have pain, jaundice, weight loss, pancreatic mass, and the treatment is steroids. Coming towards a very important cause of abdominal pain, that is a small bowel obstruction. uh, in a small bowel obstruction, if the patient can have high small bowel obstruction and low small bowel obstruction. If the patient is high small bowel obstruction, the pain is very 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 severe, and there would be vomiting, and the contents of vomiting would be gastric, and there would be dehydration and distension must would be present, but not so marked. If the obstruction is on lower level of small bowel, the pain would be there but not so severe. The vomiting contents can come to be fecal, and there can be dehydration because vomiting is later in low level small bowel obstruction, and there would be marked distension. What can be the causes of small bowel obstruction? Means and there is no problem in bowel, and the things outside the bowel are obstructing and making the bowel to get obstructed. There could be adhesions, strangulated hernia. Then we have luminal obstruction, can be due to trichobezoar. There would be the hair ball, interception, and cancer. um, Diagnosis can be made on X-ray when there is 4 to 5 step ladder fluid levels. And the classical pattern would be the patient gets pain, then vomiting, and then distension. These can be the signs of a small bowel obstruction. If the patient has paralytic ileus, it is usually after surgery, and can be due to drugs like TCA, tricyclic mm, drugs. Then we have opioids. On examination, there would be silent abdominal decreased bowel sounds, and on diagnosis, there can be air in on X-ray. There would be air in a small bowel and colon. Now, coming towards large bowel obstruction, 75% of the cases, there would be the colon cancer, which lies behind large bowel obstruction. Vomiting is not usually present in large bowel obstruction. Vomiting is a sign of small bowel obstruction. In large bowel obstruction, vomiting can occur, but later. The diagnostic triad can be pain, distension, and vomiting. On X-ray, there would be large bowel distension with loss of hostrations, and graphene enema confirms the diagnosis of large bowel obstruction. When do we refer the patient towards a specialist? If the in abdominal pain, if there is surgery indicated, for example in acute appendicitis, and there is ruptured abdominal aortic aneurysm, and all other causes, if the surgery is indicated. Then we have diabetic ketoacidosis and porphyria. We have to urgently refer the patient, and need if the patient needs early diagnosis and we have urgency, we can also refer the patients. So that's it for abdominal pain. Very important.